On behalf of Eurocam, which represents the sector of complementary and alternative medicine, CAM, in Europe, I'm delighted to welcome you all to this conference. There are participants from across Europe and even from Asia and Africa. As you may have seen on the list of participants, CAM, complementary and alternative medicine practices, prescribe non-antibiotic treatment strategies aiming at strengthening humans' and animals' resilience to infections. Another focus than the regular antibiotics have. The CAM sector believes that this innovative approach is in line with one of the objectives of the European One Health Action Plan against AMR, which is, and I quote, to boost research, development and innovations by closing current knowledge gaps, providing novel solutions and tools to prevent and treat infectious diseases, unquote. Today, a team of researchers from several European universities will present their conclusions about the effectiveness of CAM treatment strategies for infections and will suggest some innovative tools. And we invite you to participate in the debate, because your contributions can help us focus on the best way forward and help us build and strengthen alliances to overcome the remaining challenges. This is Erik Baars, Professor Erik Baars. He is a senior researcher in healthcare. Does it work? Yeah. Senior researcher in healthcare at the Louis Bolk Institute, which is a well-known organization for research and advice for sustainable agriculture, nutrition and health in the Netherlands. An institute that works for ministries, provincial government, European Commission, among many others. And in addition, he is a part-time professor of anthroposophic medicine at the University of Applied Sciences in Leiden, the Netherlands.
I would like to present you some of the results we've been working on hard with the group. And the main question I want to put here is there a contribution of CAM to reduce antibiotic use? That's the question why we are here. And if there is a contribution, then the question is it acceptable? Can we make it acceptable for everybody? And can we make it accessible so everybody can use it? How would it look in 2050 when we do not change our policies on AMR and infectious diseases? And it shows that it will be one of the most important causes of death all around the world, and it will cost the community a lot of money. The deliverables were that we would provide an overview of both expert knowledge but also scientific knowledge on CAM-IM, integrated medicine treatments of upper respiratory tract infections or RTs. And to develop also a decision-making tool for doctors, and later on we thought it would be good also to have this available for patients at the European level, and to provide a communication platform for all this information on the CAM contribution. We have 4 projects. One of them is a narrative review, which is about mapping. What do we know? What is the contribution of complementary alternative medicine to reduce antibiotic use? Which domains are there? Second one, we decided to do the systematic review of systematic reviews of RTIs, respiratory tract infections, to bring together the available scientific knowledge. A survey on expert knowledge, I will tell a little bit more later, and also about the monitoring of CAM treatments. So what is there in literature about how do doctors prescribe non-antibiotic CAM treatments for RTIs in daily practices? So this is the level where the scientific evidence comes from, and this will help to make CAM treatments more acceptable. So this is the acceptable side. The second one is here about tools, making decision-making tools, making patient decision aids, making information tools, which will help doctors and which will help patients to choose on a rational basis, being informed for a CAM treatment for their respiratory tract infections. So this will make it more accessible. So we need this information from science, and we have to make it accessible so patients and doctors can use it in daily practice. Just a little bit about the background. You can read this more broadly in your conference paper. if you look in primary care, if you look at respiratory tract infections, you see that in most guidelines in Europe, for the most instances, antibiotics are not indicated. But if you look at practice, the gap between the guidelines and daily clinical practice, you see that antibiotics are still commonly used. And the reason for that is that there's both attitudes of doctors and patients. Doctors want to prescribe often, and doctors have a background and are being educated, and patients want to be treated. So we think that delayed prescription strategies in which you offer a patient antibiotic prescription, that you say wait for it for 1 week or something and try a non-antibiotic, for example, a CAM-RTI treatment during the delayed prescription periods. And if you do like this, you might not need the antibiotic at the end of the week. So this is a nice strategy in which CAM treatment can really be integrated in conventional guidelines. So we have promising treatments for RTI, and these indications are based on 3 categories and types of knowledge. Based on systematic reviews, based on the survey, on the expertise of CAM experts, and based on most prescribed in daily clinical practice. Now let's go to accessibility. So how do we get it accessible for the stakeholders? So can we make these promising CAM treatment strategies accessible for conventional doctors and patients? And we said, well, there should be a few criteria. They should fit with the conventional guidelines, so that doctors say, okay, it's in line with what we already do, and it's adding something to what we already do. It should be evidence and or experience-based. This refers to the 4 studies I mentioned before. It should meet both the doctors and the patients' demands for treating RTIs and symptom relief. And it should meet the specific national context. It should be in line with the specific national regulation. It should meet what is there, what is accessible. In the UK are different CAM treatments available than in Germany, for example. And we would, the design would be that it's about a delayed prescription strategy with effective and safe non-antibiotic RTI treatments during the delayed prescription periods. So what I said already previously, it's about delayed prescription and adding something so that patients and doctors are able to treat and be treated. And the structure in which we want to have this is about a decision-making tool, a patient decision aid, and doctors and information leaflets.
Let me first introduce Esther. Esther van der Werf is a lecturer in epidemiology, epidemiology of primary care infectious diseases, and is working at the Bristol Medical School of the University of Bristol and the Centre of Academic Primary Care. She's an epidemiologist and trial manager with many years of experience in research, teaching and study management, and author of dozens of peer-reviewed scientific publications.
This slide shows you that if you're living in a country which is green colored or light green colored, you will consume the least antibiotics in 2017. And it also shows that if you, for example, live in the Netherlands or in one of the Scandinavian countries, you will consume less antibiotics than the British people do, and the British people do consume less antibiotics than the French and Italian. So that's basically what this slide shows you. The next slide I will show you is about antibiotic prescription rate, which is probably not a surprise that it is comparable and goes in the same direction. So there is variation in antibiotic prescription among countries. The Netherlands always traditionally has the lowest antibiotic prescription rates, but also Germany and the UK do have relatively low prescription rates. More importantly, this picture shows you that there is variation. Well, variation in prescription of antibiotics, both within countries and across countries, may indicate poor practice, which increases the risk of adverse events for the patient. It could also indicate a waste of healthcare resources. And more importantly, it contributes to the rise in antibiotic resistance. As you know, we are a research group with an interest in integrative medicine. So we were wondering, is there a difference in prescribing behavior between GPs, conventional GPs, and GPs that are having an additional training in integrative medicine or complementary and alternative medicine. So that's where the research is about what we're doing. Despite the very small proportion of IMGPs, so only those 9, our data still shows that significantly fewer total antibiotics and RTI-specific antibiotics were prescribed at IMGP surgeries. This is to show you that we're very pleased that it got published in the BMJ Open in March 2018, which I think was very good for the project and also for the CAM community that it was published in a nice journal. So I've got 3 take-home messages for you. The first one is that we found that knowledge and experience of clinicians and patients matter, as do socioeconomic and cultural factors, and that it's very necessary that we are going to build capacity. Then, respiratory tract infection is an area where the desired reduction in prescribing could take place. Because we didn't find any difference between the UTI prescriptions, I feel we really should focus on the RTIs first. And what we can do, or what we probably should do, is to see whether we can explore which additional treatment strategies that are safe are being used by these GPs with an additional training in integrative medicine, and to see whether they could be used to assist in our fight to or against AMR. And probably if these treatments could be integrated in patient information sheets or decision-making tools in primary care.
Our next speaker is Dr. Merlin Willcox. He combines his clinical work as a GP at the Health Centre for Homeless People in Oxford with research at the University of Southampton. And he is an academic clinical lecturer in general practice at this University in Southampton. And his research interests include primary healthcare for disadvantaged populations and traditional medicine. And he's currently working on a few projects in Africa and trials of herbal medicine for malaria. And in addition, he is involved in several research projects on herbal medicines as alternatives for antibiotics. And he's now presenting a systematic review of qualitative studies of CAM treatment for acute respiratory infections. Yes.
I'm going to present 2 studies. The first one is a systematic review of qualitative studies about what patients and doctors think on the use of complementary therapies for respiratory infections. And then the second one is about development of patient information materials. So for the first systematic review of qualitative studies, we wanted to know, what do patients, health workers and the public think about the use of complementary medicine for the treatment of acute respiratory infections? And what are the barriers and facilitators to the use of CAM for reducing the overuse of antibiotics for respiratory infection? For this project, we focused on the second one of these, trying to develop some advice tools or some standardized advice which could be given to patients and health professionals. Looking at the systematic review done by Esther and Erik, of all the CAM treatments that he mentioned with positive results in these systematic reviews, there are only 2 which are actually available in the UK. Many of the others were traditional Chinese medicines, none of which are legally available in the UK. Some of them were for herbal medicines from other European countries which are not available in the UK. So these 2 are Andrographis paniculata, which is available from Pucker Herbs, and there's a systematic review actually published by some of my colleagues in Southampton, and which shows very briefly that and patients who took Andrographis alone, compared to usual care, got better 3.5 days quicker than those who were taking just usual care. So it seems to be effective in quite a large number of trials and quite a large number of patients. The second one is Pelargonium sidoides, which is marketed under the name of Calorba by Schwaber, and this is sold over the counter in the UK as well as in many other European countries, I believe. And there is a Cochrane review on this, and with many results, but this is a brief snapshot of one of those tables on acute bronchitis, showing that there is a very significant reduction in patients who have failed to improve by day 7. Basically, it helps people get better quicker. But this is based on 2 trials which are relatively small. So the authors conclude that there's need for more research. The first question we discussed is, should we have actually a patient decision aid, as was first mentioned in the project, or an information sheet? And the feedback from GPs in the UK was that actually treatment of respiratory infections is not really a complex decision. The decision aids that exist tend to be for complex decisions, like if I have prostate cancer, should I go for radiotherapy or chemotherapy or radical surgery? Complex decisions, whereas these are infections that people get quite often. I expect most of us in this room get these infections once or twice a year. So people basically just want some information rather than a complex decision aid. The other piece of feedback is that actually we should try and discourage patients from seeing doctors for simple respiratory infections. Because, at least in the UK, our health service is already overloaded. And if people can cope with these things on their own, that would be a very good thing. It would save costs. And actually, the biggest risk factor for getting an antibiotic prescription is seeing a doctor. So the best thing is not to see the doctor. So we need to provide people information on over-the-counter treatments and incorporate this into existing evidence-based information sheets.
Okay, let me introduce to you Professor David Martin. He is Professor of Pediatrics at Tübingen University in Germany and Senior Consultant for General Pediatrics with specializations in treatment of diabetes, cancer and endocrine disorder. And Senior Consultant for General Pediatrics with specializations in treatment of diabetes, cancer and endocrine disorders at a hospital in Germany. And he's head of the Institute of Integrative Medicine at the Medical Faculty of the University of Wittenberg in Germany.
What I propose is that by teaching parents how to think of fever and how to deal with fever, we can make an additional contribution to the problem of antimicrobial resistance. And I came to this theme because when you do your professor thesis in Germany, one of the things you have to do is hold a lecture on a theme you have not done research on, and that is not part of your clinical main jobs. And as a pediatric endocrinologist and oncologist, general pediatrics and fever wasn't my main job, but it's the second most prevalent symptom in healthcare after coughing, which we've just heard about. And the conclusions I came to in this lecture to the faculty and to the students was that fever is a resource which is known to most of you and now more and more known to most of the people in the world. An editorial in 2016 came to the conclusion, my God, we've known this for quite a few years, that fever is a resource, and yet we still have fever phobia all around the world. People are afraid of fever. Briefly after holding this lecture, I was asked to whether, along my position at the university, I would take the interim lead of the pediatric department of the Filter Clinic, which is a large hospital for anthroposophic medicine, which is also responsible for the Stuttgart airport, and they were ready to experiment with me. When I arrived, I said, how about we say there's no upper temperature for lowering the fever? They were already very fever-friendly. But they did have, most of the doctors and nurses, kind of an upper threshold of 40 degrees. We've done that for 4 years, and we have one child who we immediately suppress the fever when he comes in. He's a handicapped child, disabled child, and he starts profusely vomiting when he has fever. We have a couple of more children who have temperature-dependent epilepsy. Some epilepsies get better with fever, others get worse. They also get treated immediately. But that's it. All the other children do fine. And we totally agree with the NICE guidelines that say that we shouldn't be basing our threshold on the temperature, we should be basing that on how well the child is doing. What does accessibility mean today at a time where parents do not come in the evening to the doctor's practice if he says, I'm doing a parent evening, because they're all busy on their mobile devices, looking at them every few minutes, on average 3 to 5 hours per day. And this together with the fact that one of my doctoral students who went out to the various pediatric practices and recorded the way the pediatrician and the GPs explain to the parents how to deal with fever, and came to the conclusion that it's so heterogeneous that it's no wonder that there's such a confusion. This was, I presented then this problem to the German Ministry of Health and Research, and they gave me a grant to develop a fever app registry. We want to develop an app which gives parents information and allows them to input their information on how they deal with fever and what they measure, which in turn informs us about whether the information we give them is useful or not.
Looking at all the presentations, I think it's very clear that we are on our way, and things what we are doing is promising, and we have first prototypes. We have a lot of increasing evidence, and we just here wanted to summarize what are the challenges we are facing until now. So there are three major challenges now. First is, of course, to increase the quality of the evidence. We need more evidence of CAM treatments for infections, but also on these information tools and these fever apps, etc. So if we do this and we have more and more evidence and better quality of evidence, this will increase acceptability. Again, this is one of the major issues. The second thing is that we further want to develop and test the information tool on safe and effective CAM treatment options, and of course the fever management, and this should be done within the national context, so that it's in line with national guidelines, in line with what is accessible in these countries. So this is about increase of accessibility. And we would like to do this work on not only for today or next year, but on a long term, so that we are really able to organize this work, the scientific and supporting work in the field for infections on a regular basis in Europe, so that we have an increase of sustainability.
Ellen Bloomer from the European Public Health Alliance. I just wondered, with regard to the quality of evidence that you're talking about, I wondered why you think we don't have that quality evidence, given that many of these treatments have been around for a long time. So I just wondered why you thought that was. Maybe it's a question of funding, maybe it's a question of publication bias. So I wondered if anyone had an answer to that.
If you look back, there has been a lot of lack of quality of CAM research in general. I think if you go for 20 or 30 years ago. You see that the quality of the studies is improving now, but if you go back in the time, it's often a low quality. On the other side, there is more and more what I told you about this AMSTER checklist, which is a new checklist, which is really very strict. And I think if you look now at the quality of the systematic reviews, which I showed are low, very critically low, I think most of the systematic reviews nowadays will be in these categories, because the threshold went up, and the level of you have to be very, very good and very strict to have a high quality of evidence.
Yes, it is about funding. So those studies that have undergone trials and that were included in the systematic reviews are mainly of products that are being sold by a company, and most of the trials are funded by a company. Most trials of conventional medicine are either publicly funded or funded by the pharmaceutical company. And there's very little public money for doing research on complementary medicine, which there should be, really, if we want to get objective research done.
Often when you look at the evidence, for example, just taking fever management, we have come to the conclusion scientifically it's not about lowering the temperature. Well, there are a lot of trials for paracetamol and ibuprofen that show quite well, with quite high quality of evidence, that they lower the temperature. But since that's not the outcome anymore, the outcome is how is the child doing, psychologically, physically, and immunologically. And for that, we have hardly any evidence for something we're doing all around all the time. And if we look at the antibiotics, we come to the same conclusion over the last 20 years. We have Werf, because of this, drastically reduced and delayed the way we prescribe antibiotics at the universities, but this is still only slowly infiltrating into general practice and general pediatric practice.
My name is Robert Johnston. I'm on the board of a group called the European Forum for Good Clinical Practice, and also on the International Foundation for Integrated Care. But my main role is I'm a patient representative. And I just want to pick up one point that Erik made right at the end, was lack of stakeholder involvement. I think that's one of the big problems why complementary therapies are not being more widely used, more widely understood. You know, when you get the patients behind you, funded in a way to lobby for something that they've used themselves and it's worked for them, and they want it for their children and their relatives and friends, then you'll start to go somewhere. You have to work with stakeholders much more than you have been doing in the past. Thank you.